Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's January 2025 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice this month is an original article entitled Association of Informal Caregiving and Menopause Symptoms in Midlife Women, a cross-sectional study. It is authored by Dr. Mariam Sadadine and colleagues from Mayo Clinic in Rochester, Minnesota, Jacksonville, Florida, Scottsdale, Arizona, and Eau Claire, Wisconsin. Informal caregiving refers to the unpaid provision of care and/or support of a family member or close friend. Rooted in altruism, such caregiving may require a considerable time commitment, impose stress and anxiety in diverse ways on caregivers, reduce the attention of caregivers and the administrations to their own personal needs, health, and desired lifestyle, and induce financial constraints as caregivers reduce their working hours and/or incur out-of-pocket expenses. In the current issue of Mayo Clinic Proceedings, Sadadine et al. Questioned whether caregiving may be attended by a heightened menopause symptom burden. These investigators undertook this study because of the following considerations. First, the majority of caregivers in the United States are women, the majority of whom are partnered, married, and with average age of such caregivers being approximately 50 years. Second, the duration of caregiving in the United States is some 5 years, thereby raising the likelihood that women who are caregivers are likely to experience the menopause transition in the course of caregiving. Third, as the U.S. population continues to age, the number of women involved in caregiving has also increased. Fourth, women in the United States are generally having children later in life, such that they may have, in midlife, the dual and concurrent commitment to care for their own children as well as an aged adult. Sadadine et al. Undertook a survey of more than 4,000 women receiving primary care at one of 4 Mayo Clinic sites. Menopause symptoms were assessed by the Menopause Rating Scale, and caregiving status was self-reported. The essential findings were that the burden of menopause symptoms across all symptom domains increased as the weekly number of caregiving hours increased, and this association persisted on multivariable analysis that assessed relevant indices of daily stress levels and mental health. Sadadine et al. Are to be commended for highlighting this topic in general, and in particular for the novel insights their study provides. In their discussion, these authors offer the compelling suggestions that caregiver status should be included under the rubric Social Determinants of Health, assessed and documented in the medical record, and considered for its potential exacerbatory effects on menopause symptoms and its other risks. Caregiving is essentially altruistic in origin, but it should not be a zero-sum game, wherein the beneficent and unfettered provision of care and support then imposes a stressful and inordinate burden on the caregiver. In this regard, this study provides needed advocacy for healthcare policies and support systems that can aid and ease the burdens of the caregiver, including those that worsen menopause symptoms. Our first highlight article this month is a special article entitled Decoding Obesity Management Medications and the Journey to Informed Treatment Choices for Patients. It is authored by Dr. Afton Kobal from Mayo Clinic in Rochester, Minnesota, and colleagues from Mayo Clinic in Rochester, Minnesota, and Jacksonville, Florida. Mayo Clinic Proceedings has highlighted this topic by recently publishing reviews on the pathogenesis and classification of obesity, metabolic bariatric surgery, and the role of bariatric surgery in enabling kidney transplantation in obese patients with end-stage kidney disease. This special article by Coble et al. Complements such reviews by discussing obesity management medications within the context of the range of therapeutic strategies for obese patients, especially those with a BMI greater than or equal to 35. Such a spectrum involves strategies with low efficacy and low risk, such as reduced caloric intake and increased physical activity, and those with considerably higher efficacy but greater risks, such as metabolic bariatric surgery. Obesity management medications and endoscopic procedures are broadly considered intermediate in efficacy and risk. Incretin-based obesity management medications, such as semaglutide and tirzepatide, initially developed for the treatment of type 2 diabetes, were found to promote weight loss because they delay gastric emptying and promote satiety. Current interest in incretin-based obesity management medications, partly driven by drug advertising and the media, is enormous, as obesity management medications may achieve up to 15 to 20% weight loss. Rising in prevalence, obesity and its comorbid conditions are major healthcare concerns. Coble et al. Emphasize the following considerations, among others, in using obesity management medications: the need to understand the patient's weight loss expectations, patient recognition of the side effects of obesity management medications, the risk for weight recurrence when obesity management medications are discontinued, considerable variability regarding patient access to obesity management medications and insurance coverage, the advisability of increased physical activity and appropriate dietary alterations when obesity management medications are used, the consideration of metabolic bariatric surgery if obesity management medications are not tolerated or ineffective, diminished access to obesity management medications in minorities, and the need to avoid weight stigma and bias. Coble et al. Also underscore the need to optimize protocols for obesity management medications, especially prior to the initiation of obesity management medications, and to involve nutrition experts, physical therapists, and behavioral counselors as indicated for comprehensive management. The authors provide helpful tabular summaries of the 8 currently approved obesity management medications and key considerations regarding the choice of obesity management medications or metabolic bariatric surgery in managing patients with a BMI greater than or equal to 35. As the authors emphasize, obesity is a disease underpinned by genetic, metabolic, environmental, and behavioral factors, and does not reflect loss of willpower or moral weakness. Obesity management medications represent a fundamental therapeutic advance, and their role, position, and salient considerations within the spectrum of management options for class 2 and 3 obesity are all wonderfully discussed by Coble et al. Our second highlight article this month is a commentary entitled Lithium and Kidney Disease. It is authored by Dr. Mete Ursis and colleagues from Mayo Clinic in Rochester, Minnesota. An unending challenge in medical practice resides in managing a major disease for which there is an effective and approved therapy, yet one that may incur significant adverse effects. Lithium is the cornerstone in the management of bipolar disorder and may be used adjunctively in unipolar depression and as an anti-suicide medication. Lithium's use, however, has long been associated with chronic kidney disease, and indeed the presence of significant chronic kidney disease contraindicates its use. The most common adverse kidney effect of lithium is nocturia and polyuria, arising from arginine vasopressin resistance. While arginine vasopressin resistance may cause troublesome and lifestyle disrupting symptoms, it does not reduce glomerular filtration rate or cause chronic kidney disease. Chronic lithium administration, as shown in preclinical studies, however, may also cause chronic kidney disease, a conclusion supported by human observational studies. Both in experimental models and in human biopsies, the lesion is chronic tubulointerstitial disease. The commentary by Ursus et al. Takes a discerning and timely look at such observational studies with the following key messages. Kidney function evaluation often utilizes serum creatinine as a glomerular filtration rate marker. The latter may be confounded in several ways, as for example by dehydration, muscle wasting, or age. Chronic kidney disease is generally defined in part by decreased kidney function for 3 or more months. Yet in some studies, a single serum creatinine measurement is used in assessing chronic kidney disease. The majority of patients treated with lithium do not develop significant chronic kidney disease, and the risk of end-stage kidney disease is quite low if chronic kidney disease were to occur. The use of non-psychiatric populations as control groups failed to consider the effect of comorbid conditions or other medications used in bipolar disorder. Depressive symptoms per se in bipolar disorder may be attended by a reduced glomerular filtration rate, and other mood stabilizers and antipsychotic medications have been associated with chronic kidney disease. The authors emphasize attentiveness to risk factors for chronic kidney disease in lithium-treated patients, for example, duration of therapy, high trough levels, and other medications and comorbidities. And they discuss the controversies and challenges in discontinuing lithium. Finally, they point out the need to develop risk prediction models, genetic tests, and other biomarkers that may predict those patients at risk for chronic kidney disease. As is universally relevant when using an effective and endorsed medication, yet one with significant risk profile, Ursus et al. Underscored the importance of relative benefit and risk assessment, shared decision-making, minimizing other potential risk factors, and attentive follow-up, both by clinical assessment and by relevant biochemical tests. You can access these highlights and editor's choice articles free of charge during the entire month of January. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You will also find links to our social media by clicking the links in the gray bar at the top of the home page from the Connect menu to follow us on Facebook, X, formerly known as Twitter, and YouTube. On our YouTube channel, you'll see full-length author interviews called Insights, and our MCP 60 seconds video article synopsis. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insight podcast recordings, which are available from our website on the homepage as well as through iTunes. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings. We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us Our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.